Welcome again. This class will be a general introduction to the course. I would like to focus on several aspects, starting from the theoretical understanding of science and medicine. Now, this is a very broad topic to discuss, so I really encourage you to review the slides as we progress through the semester. Because some of the materials that are there are very important to understand future lectures as well, and also of note when we will discuss current scientific literature. I will keep updating the bibliography on the portal to provide the most recent discoveries in different branches of CEM, complementary, and alternative medicine. Starting with the slides. The first slides talks about therein, which is a Greek term that indicates, as the slide implies, an observational, contemplative, and rational type of abstract or generalizing thinking, as well as the result of such thinking. Now, why is this important? Well, it is important because we have to understand what defines the scientific method from the perspective of medicine first. And before we embark on a deeper understanding of what medicine is and what distinguishes it from standard medicine, complementary medicine, integrative medicine, traditional ethno-medicine, all these labels, we need to understand what it means to apply the scientific method in medicine. Because something that I want all students to understand is that the science that we use in hospital medicine, Western medicine, biological evidence-based medicine is and has to be the same science that we use for other branches of medicine, whether we want to accept complementary, alternative, integrative medicine as a thing, or whether we want to reject it altogether, right? So let's focus on what we mean by theory first. Now, what is a theory? Let's take a look at the slide. The components of theory are, for the most part, assumptions, domains, range of applicability, constructs, and hypotheses. When I say for the most part, it's simply to justify some differences in theoretical approach within epistemology. Okay? We will talk about epistemology as the field of the study of science, the philosophical understanding of science, the theoretical understanding of science, what it means to be a scientist. Okay. But those components are pretty much the standard that we should abide by in the context of medical sciences, right? Now, what else should a theory have? It has to be logical, it has to be consistent, it has to be parsimonious, it has to be testable, it has to be integrated with previous research, and it has to be multiple areas of scientific investigation. So let's take a step back here for a little second. Now, if you go back to the components, with assumptions, we mean the basic question that we need to address. As we will see in future slides, one of the best ways to start a research, a medical research, just as any other empirical research, is to have a clear idea on what questions we want to ask. And the questions will be very simple, very easy to understand. We cannot afford to have open-ended questions, essay-like questions in this context. I mentioned that because another class I teach has to do with motivational interviewing, which open-ended questions play a big role. The question has to be straightforward, easy to understand, so that we can get a straightforward answer. Whether the answer is something that we expect, or it is a yes, or the answer is a no, something that will reject our assumption, well, that has parts. It's part of the science that we want to achieve. So the assumption have to be created in a way that can be verified. Okay. Now, in the context of testable, well, testable and verifiable are at this level pretty much synonymous. We will see how different internal validity from external validity is. Whether validity and reliability are the same thing, whether the things we find to be true under certain constraints with our products in our lab can be extrapolated and made universal, so that our research can provide new evidence for other research that focus on the same domain, or that can be beneficial to other branches of medicine altogether. This is something that has to be verified as well. Of course, a theory has to be logical. It has to make sense. And in that sense, I will also like to mention quite briefly Occam's razor, in that sense, has to be parsimonious. We don't have to add anything else to justify, philosophically or not, the rational element in our theory. Careful here, we're still talking about the theoretical realm. We're not talking about a completed study yet. Alright? This is very, very important. It's an important distinction to make, because there are indeed different approaches when we apply that to complementary alternative medicine. Okay? Now, integrative previous research, yes, and yes again. This has to do with meta-analysis. In other words, we cannot ignore what has been researched, studied, and published before. This is something that we will touch upon several times throughout the semester, because one of the logical fallacy that at times you can hear some proponents of complementary or traditional medicine is that, well, this technique has been with us for 2,000 years, therefore it has to be true. And unfortunately, just because something is very, very old, it doesn't make it true. And that's something to do with verifying whether your results can be replicated, and whether you are aware of these replications, whether you're aware of the most current research in that field. This is very important because in science, of course, it's much easier to get a lot of fame if you get the results, of course, that you expect for a groundbreaking study, but it's as important to dedicate one's time to restate the obvious to some extent, to verify whether any type of study has been produced in the past still makes sense. If you have any reason to doubt it or not, whether your assumption is the same as the assumption of the scientists that led the previous studies or not, we still have to replicate this study, because this is how science progresses. Dealing with multiple areas of scientific investigation, this by definition has to do with complementary and alternative medicine. We will see that complementary and alternative by definition are terms that can be problematic for a variety of reasons. One of the reasons is complementary to what and alternative to what. And the classic question is, if it works, it helps, and it's scientifically based, why don't call it just medicine? Why is there a need to say this is this type of medicine or that type of medicine? If it's medicine, it's medicine. But one of the things within complementary alternative medicine is this strong understanding that we had to be at least culturally aware of the ethno-historical and cultural component of practicing medicine. We are, after all, a product of our time. Okay, so we had to monitor certain parameters based on other areas of scientific investigation for that very reason. So again, going back to the basics, how do we know that a theory is scientific or scientifically reliable? Well, we have to understand the principle of falsifiability, okay, which is pretty much synonymous with testability, verifiability. Statements, hypotheses, or theories have falsifiability or refutability. On the contrary, if there is the possibility of testing or observing it to showcase how false or how true it is. Therefore, the term falsifiability is synonymous to testability. So we assign a value, okay? So if the result, if your statement, your main hypothesis is true, you assign, for instance, in this context, value 1 as a standard. If it's false, you assign a value 0. Now there's a little joke that I posted after this slide. I cannot pronounce the joke because otherwise it will not be fun at all. I hope you find it at least interesting. So we'll move on to the next one. Okay. Now the second part is the pyramid of evidence. Now some of us might think that science is this big, well-defined block in which something is either true or it is not. Now, what I just said makes sense from the perspective of hypothesis testing, and there's a lot of statistical analysis that allow us to do that within biostatistics. So you need to understand, student t-tests, p-values, and so on and so forth. But in terms of what we're studying, how we're studying, things can get a little more complicated. So in your slide, you'll see this pyramid of evidence, the house of evidence, in which at the bottom you see ideas, opinions, editorials, and anecdotal evidence. Now this is of course just the beginning of our research, but it's nevertheless a very good start. And I want to mention this because one of the wonderful jobs that, for instance, nurses do in their hospitals, and I'm biased, my wife is a nurse, and I believe that nurses play a fundamental role, is observing things, reporting on things, even if there are things such as perceivably small changes in a patient presentation after, okay? So, if this report is a observed, clinically reported analysis, then of course we're talking about a case report that can also be utilized in the context of laboratory medicine. But even general ideas, general opinion, anything that brings new information to the conversation is very, very important. Okay? It's the basis of the pyramid. So above that we have case series and case reports, and above that we have cross-sectional studies and case control studies. Right? Now, the more information we add, the better it is. That's in short what we're trying to achieve. Now, don't confuse this complexity with Occam's razor and a parsimonious theory that we discussed before. In this context, we're talking about the pyramid of evidence. Okay, so we're talking about the research itself. We're no longer limiting ourselves to the theory. Okay, the theory has to be as simple as possible. The study has to take into account the vast majority of possible determinators of the theory. You have to be accountable, you have to account all the variables, you have to monitor everything else that's going on in terms of possible influencing factors, internal and external to study, and all the way up to RCT, the randomized controlled trials. In the best case scenario, we'll have a double-blind randomized controlled trials, and double-blind in the sense of the study is blinded to the subject, so the subject does not know which group the subject will fall in. For instance, if you're studying the efficacy of effectiveness of medication, you have a group that will receive the medication and the other group that will receive a placebo, something that might look, taste, and feel like the real medication, but it's just a sugar pill, so to speak. And the client and the subject should not know which category, which group it will fall into. It will be single blind, and double blind is same thing for the administrator of that pill, right? It has to be, of course, randomized in the sense that you assign scientifically fairly the subjects to groups, and there are several ways to obtain this randomization, cluster cohorts, and so on. And above that, the platinum area, beyond the golden standard, is of course system reviews and meta-analysis that take into account several randomized controlled trials, double-blind case controlled trials, and see what kind of pattern, what kind of epidemiological pattern, what kind of curve that emerges over a certain period of time. In the next few slides, we will talk about different types of research, and for now I just want to focus on differences between quantitative and qualitative research. Now, my field is psychology, psychiatry, neuroscience, so I'm biased because I'm especially fond of brain activity and neural underpinnings of behavior. And so I deal with both quantitative and qualitative research on a daily basis. And the strength of quantitative research is, of course, the fact that quantitative research, by definition, deals with facts, numbers, and solid elements to investigate. Okay? But I don't want people to think that qualitative research is a slightly less precise version of research. I really don't like this definition. You might hear that, well, if you do qualitative research, you just create a survey, you do a questionnaire, and then you're done with it. You don't really have to do the science. Well, in terms of what you're doing from the statistical perspective, you do exactly the same thing, because even qualitative research, for the most part, has to be encoded in numbers and values. So you still need to figure out ways to transfer your answer, whether those answers are modulated by an open-ended questionnaire or a survey, or in best case scenario with some numbers already, a Likert scale, for instance. You need to transfer that information into numbers to plug in and create your mass histogram and your statistical analysis. So you have to do the work anyway. Granted, there might be more room for possible mistakes and bias, because of course there is a higher level of interpretation as opposed to studying the results of analysis of patients' vitals, for instance. But it's also true that qualitative research focuses on the patient, on the subject, on the patient, on the client as a person as well. So it provides a lot of extra layers of understanding, the complexity of which cannot be necessarily reduced to the same level of understanding you find in quantitative research. But I'll advise you to take a look at the slide to have a better understanding of what I'm expressing here. Alright, so a general overview of the textbook here. The textbook has to do with a scientific understanding and a philosophical understanding of medicine. So during this course, we will use that as a reference, and every time I will mention theoretical and philosophical approaches to medicine in general, I'll refer to the textbook. But when it comes to current scientific studies, then of course this is something that has to be updated constantly. So please refer to our portal system, to Blackboard, for the most updated information, and that applies to current research in the context of complementary alternative medicine and in medicine in general. Right? So I will skip for a second the introduction to the textbook, but I want to make sure that at least I cover the main elements. So there are 7 main parts. In the first chapter, the textbook examines a brief history of medical philosophy. So we'll talk about why do we have to study philosophy if we want to understand medicine, okay? And what relationship exists between different types of scientific analysis in the context of medicine. So it's a general overview. So you have general aspects in the application and epistemological consideration, define the questions, medicine is art, science, and technology, and find self-image, academic achievement, and healing process. In the second chapter, philosophy as a basic approach to medicine. Here we will talk about the usefulness of philosophy to understand what it means to do medicine, practice medicine. We'll talk about hermeneutics and evidence-based medicine. Evidence-based medicine is a term that I will use throughout the semester, and at times will be synonymous with Western medicine, the medicine that we practice in our hospitals here in the United States, for instance, and in Europe. And for hermeneutics, we'll have to spend a little more time, so this is just an introduction. Truth in method. This has to do with both biostatistical, bioepidemiological analysis, and what can we learn from disciplines akin to medicine, such as psychology, from the perspective of research. Chapter 3, between neuroscience and phenomenology. This is more the most complex chapter, so I will not spend too much time analyzing it here. One of the areas in which this chapter is so important is to better understand ethnomedicine, which again, as a term, it's really a westernized understanding of certain types of traditional medicines that by definition involve a transcendental, at times spiritual or even religious ritual element to healing, and this is something that is discussed at the beginning in chapter 3. So we're suggesting a model and we do an analysis of the mind-brain problem. Chapter 4, the patient at the center of therapy, communication, perception, and self-perception, and then the search for meaning. Now, this chapter is important because we should never forget, I should say, the point of doing medicine. The point of doing medicine is first and foremost to help, to heal, maybe to cure, although that is very often too strong a term. In other words, we are doing medicine for fellow human beings, or for animals as well, in the context of veterinary medicine. But everything is medicine. Environmental medicine is medicine. Caring for our planet is medicine, correct? In the context, however, of human beings, patient-provider relationship is essential to understand how things change in the lab, how to better interpret the results, and also, even more important from our perspective, to better help the patients in their path toward well-being. Chapter 4 is the description of this class, you could say, complementary and traditional medicine. In the first part, we will examine the placebo and the nocebo effect, its opposite. And the second part, we will discuss the difference between Western medicine, Eastern medicine, and this term that the textbook adds, Central medicine. Then, from the perspective of why, how, and through what parameters we study, for instance, the validity of a therapeutic approach or a new pharmacological intervention, efficacy, efficiency, and effectiveness. And finally, because complementary medicine is a field that is so close to disciplines such as medical anthropology, for instance, culture, and identity. Finally, chapter 6, Beyond the Realms of This World. This is the more spiritual part of the textbook, something that we will discuss only toward the end of the semester because it goes a little beyond the main focus of this class, which is again the examination of the science, the evidence, the application of complementary alternative medicine, and it has to do with the higher purpose, the higher goal, the higher and deeper meaning that a lot of complementary and alternative medical practices have. And of course, this is congruent with some element of analysis of spirituality and religion, history and philosophy thereof. Part 7 is not necessarily a medical-based chapter, it's translational science, and it's the application of everything we will study in this semester for the benefit of the general population, including policy-making perspectives and healthcare. Then there is an appendix in our textbook, an empirical research conducted at the University of Vermont Medical Center on the Inpatient Psychiatry unit. We will talk about that also toward the end of the semester, but for now this will be the main content of the chapter 1 through 7 in your textbook. Now, starting today, we will start, of course, with chapter 1, a brief history of medical philosophy, and we will see what it means to study medicine, first of all, right? Now, some of you might be very familiar with the history of medicine in general, the history of Western medicine at least. In this lecture, I will provide a general overview of the most important aspects of medicine as a discipline, as well as all the related either sub-fields or separated fields of investigation, especially psychosomatic medicine, which is going to read here from the slide, philosophy of medicine, which is similar to philosophy of science, at least from the theoretical perspective, behavioral medicine, clinical psychology, medical psychology, positive psychology, counseling, motivation interviewing, humanistic psychology, and so on and so forth. So you will see that I will talk about philosophy and psychology a lot in this semester, and hopefully in the second half of the semester will be more apparent and obvious why that is the case. All right, and of course there are certain terms that, depending what school of thought you're coming from, might be synonymous. For instance, is there a complete difference between behavioral medicine, for instance, and medical psychology? To what extent are we studying medicine in order to provide a higher self-awareness so that the patient can take a better care of themselves? And to what extent are we studying psychology so that we apply our ability to detect and understand human behavior, cognitive patterns, and emotional response in the context of medicine? Well, there are fields that by definition are hybrid fields, and from our perspective, complementary alternative medicine is definitely one of such cases. Before we come to the term complementary alternative medicine, I have a few slides that talk about the general development of science, and then just create a list of the most ancient academic institutions in the world. And it is impossible to have an exhaustive list of sciences, time immemorial, but at least I want to provide some evidence of the fact that we are standing on the shoulders of giants. Now, the oldest university with this name and structured in exactly the same way as modern universities are, at least from the perspective of degrees, although we will see that there are certain differences in the way titles are used in different countries of the world, is the University of Bologna in Italy, okay? 1080. That is the oldest university in the world, period, okay? The first university in modern science, the first institution granting academic degrees, and this had to do with the cultural structure and development of the time in Central and Southern Europe. We will see how the very term doctor, for instance, was a term that had absolutely nothing to do with medicine at first. The first term doctor was more related with theology, you could say, or spirituality, at least, doctor of the church. And of course, that institution played a major role in Europe at the time, especially in Italy, and therefore areas such as the city-state throughout Italy, but especially cities like Bologna, Naples, and Catania and Padua were European powerhouse for science. So 1088. However, if we think about the oldest surviving academic institute, we should think about the Al-Azhar Madrasa in Egypt. Now, this madrasa became university only in 1961, and that's why it's not awarded as the oldest university in the world. But we always need to keep in mind two things. First of all, that it's a false assumption to think that only in modern times science navigates and shared in a way that was never possible before. Granted, the internet allowed for a faster rate to be able to share information, but science, by definition, was always shared in multiple social, cultural, and geographical areas. Now, in this list, I didn't even include the Indian continent, for instance, and if you just think about the oldest writing system in the world, it's impossible not to think of the Indian continent as well as the Middle East, modern day Mesopotamia, the equivalent of Mesopotamia, so Iraq, Iran, Syria, Palestine, Egypt, and Israel. But we're focusing on university as academic institution to see if we have the right to call our medicine, the Western medicine, the true medicine, so to speak. Right? So from institutions in general to historical figures. Again, here are the list will be never ending, so I just mentioned the most important ones. Starting with Hippocrates, not because he is the most important figure in the history of medicine, but because he's one of the most quoted, at least in the West. If you think about the Hippocratic Oath, which wasn't really written by Hippocrates in the way it's read nowadays, but it's nevertheless one of the founding fathers of clinical medicine, 460 BC. Then Aristotle, of course, is the father, one of the fathers, I should say, of Western philosophy. From our perspective, is the father with a capital F, simply because of his analysis of science, and which we'll see what I mean by that. Then the Descartes, 90, Greek Encyclopedia of Herbal Medicine, a Pharmacopoeia, and the Doctrine of Signatures. Again, not just important from the perspective of history of medicine, but because he is also one of the instrumental figures in the development of herbal medicine. Galen, well known for the theory of four humors or temperaments. Again, one of the areas where medicine, anthropology, philosophy, and especially psychology, in the context of theory of personality, plays a fundamental role. Also, the link between Western medicine, Western traditional medicine, so we're talking about the Greco-Roman world especially, and connected social, geographic, cultural areas, especially the Persian Empire, all the way to China and the Indian subcontinent as well. And pardon me, I think I mentioned Indian continent earlier, I meant subcontinent, I'm sorry. Al-Farabi, 872, in the Arabic philosophical tradition, he is known with the honorific the second master after Aristotle. There are many figures in the tradition of the Arabian Peninsula, and we will talk about at least 6-7 of them. Starting with Avicenna, he was Persian, he was a polymath, but he is also father of early modern medicine. Ibrahim Avicenna is his name, but in the West is usually known as Avicenna. Another important figures, Averroes or Ibn Rushd, 1126, medieval Andalusian era polymath. So again, both European and Arab, Andalusia in modern day Spain. So the combination of multiple tradition and philosophies. Maimonides, the father of the father, a Sephardic Jewish philosopher and physician in Moroccan Egypt. His real name is Moshe or Moses ben Maimon, 1135. Now, skipping ahead and going toward in the early Renaissance or very late Gothic period, again, depending if you are in Central Europe with the Germanic influence as opposed to the more Latin, Roman, Italian influence, Paracelsus, Bombastus Paracelsus, who was a Swiss physician, alchemist, astrologer, and pioneer of the medical revolution of the German Renaissance. We will see how alchemy, from the term alchemet or black soil, so related to the history and the scientific exploration in Egypt, is both the very last remnants of all medieval and pre-medieval spiritual, transcendental, even esoteric teaching, and the very first beginning of modern chemistry. So Paracelsus is this kind of link between the old world and the new world. A new world, however, just because we're talking about the Renaissance, that it's in itself related to a world before the Middle Ages, which were middle really from our perspective, because people in the Middle Ages really didn't look at themselves as being in the middle of something. There were nor were they dark ages either, we should say. They were less influenced by the more traditional, you could say, archaic and well-organized history of the Roman Empire, for instance, okay? For which the Renaissance took a lot of inspiration. 1622 for Marcello Malpighi, an Italian physician, philosopher, scientist. I summarized here his contribution by simply writing that he stated the body was indeed a machine. His contribution is immense in our field, but when we think about the body as a machine, as a thing we can observe and work with, a biological mechanism, something that does not necessarily warrant the same awareness of spiritual entities, for instance, that we have to think of Malpighi as a model. Now think about the time here, 1628. We will see that this is one of the areas where the mind-body problem plays a major role. We will think about Descartes or Cartesius, the French philosopher, that I think therefore I am as well. Then the next few slides have to do with the 4 temperaments, and this is a very, very important part of both medicine and psychology. So why is it so important? Well, first of all, let's think about what it means. So 4 temperaments, 4 humors, 4 ways to be in the world. Now this has to do both with the nature-nurture debate, as well as with the debates of developmental psychology, for instance. So what is the nature-nurture debate? Well, one of the debates is, are we the way we are because of heritage, whether this heritage is genetic, for instance, or pre-learned in a sense, rather than pre-learned, predetermined, learned as learned from the DNA, for instance. So we are certain blocks that will be, meant to become a certain way because we already have that mapping to begin with at birth or in pre-birth, depending on what kind of theory we follow. Or are we product of our development? And with our development, it's both an interaction of things we learn and we are aware of the fact that we are learning them, or we are subconsciously absorbing information. This is kind of the nature-nurture debate, and I'm oversimplifying things here. Now, according to this theory of humors, and in this slide here, the first slide talks about one of the earliest representations in the Middle Ages that was provided as part of a manuscript. Again, another area where we had to grant, religious institutions at the time, especially, the 3 sisters, so Islam, Judaism, and Christianity, especially Catholicism, simply because the monks and the learned rabbis and imams of the time were responsible for transmitting that knowledge toward us. And so it is true that, just a brief parenthesis here, it is true that from certain point of views, the Middle Ages were dark ages because we lost a lot of knowledge of the ancient world, especially in this context, Greco-Roman and Persian world. Okay, and part of it has to do with the changes in religion throughout Europe. Although that is a little bit simplistic because one of the issues was, for instance, during the Fourth Crusade, the tension between Eastern and Western Christianity. But nevertheless, wherever there was a religious institution, again, in the European context, we talk about these 3 sisters, the people of the book, then we have a development and appreciation for people that came before us. And the for temperament, for human components, is one of such examples that you can see in this medieval manuscript. Now, 4 humors, 4 temperaments. Well, this indicates the fact that at birth we are born a certain way. One of 4 ways, you could say. And so we are born in these boxes that allow us some room to change, to develop, but ultimately we have an essence we cannot escape, even if we wanted to. All right? Now, humor in Latin and in modern Italian as well, to some extent in English as well, having a sense of humor, right? Indicated both a physical property, a liquid, a fluid, as well as a state of being, a state of mind, and to the character. And so personality is definitely related to this theory. And of course, personality is related to persona, the Greco-Roman term, the Latin term, that indicated the mask that in ancient theater actors used to put on to change the sound in their voice. So persona, to change the sound, to create new characters on the stage. So it's something that by definition is put on. So whether a personality is something we, again, put on and we learn, or as in theory of humans, something we're born with, is the nature-nurture debate. So you have 4 main elements. You have the humor of blood, of yellow bile, or black bile, or phlegm, each of which determine a different predominant modus operandi, you could say, or modus vivendi, a state of being, okay, a way of being alive, okay. So, a sanguine person, the humor of blood, a person whose blood predominates, there's more to it, okay. A choleric person, a person in which the yellow blood predominates. A melancholic, and we use the term melancholic even in modern English, it's one of the closest terms to clinical psychology, a person in which black blood predominates. And finally, a phlegmatic person, phlegmaticos, abiding phlegm, a person in which phlegm predominates. And you know, the point here is not so much agreeing with theory. We know that those elements do not determine certain states of mind anymore. Not necessarily that they used to, but we don't believe in that anymore. So in that sense, the theory turned to be false, not real, not scientifically valid. It's also true that for a lot of our socio-emotional response, we take a look more at the brain rather than through our body. Although current scientific research disputes the fact that the brain is the only area in which certain neural and European behavior are the primary determinants of our being in the world. I'm thinking about the gastrointestinal tract, for instance. Nevertheless, this theory is interesting because it appears to indicate there are certain parameters that we tend to fall prone to embody in our life. So those four humors. Now, the next slide is the equivalent in Islamic medicine, and I'm thinking especially about Avicenna in this context. And there are wonderful studies done on his theory, and in this context I would like to simply mention Georgetown University in Washington, D.C. And their department of Complementary Alternative Medicine. The next slide identifies the classification of things according to the theory of the 5 elements. Now, the first change here is that we're not talking about 4, we're talking about 5, and yet there is still this connection between something that's observable, matter-based, physical, an element, and a corresponding mood, temperament, humor, change in being. So you see here lung, kidney, liver, and heart and spleen, okay, as primary elements, followed by the corresponding organ, okay, so urinary bladder, large intestine, stomach, small intestine, and gallbladder, and then followed by the biological element at its basis. So water, metal, earth, fire, and wood. Now, this is very important in the study of the Taoist component of traditional Chinese medicine, understanding other branches separate from medicine but coming from the same philosophical background. Think about Feng Shui, for instance, the yin and yang components in acupuncture, for instance, and many others. So this is just an introduction to TCM. So changing number, but very similar concept. Another concept that is very similar in structure, the number 3, this time is the 3 temperaments in Ayurvedic medicine. This time, this temperament does not only define a certain cognitive, emotional, behavioral predisposition, but even physical appearance, structure, and anatomy. So you have Vata with ether and air, you have Pitta with fire and water, and the one on your right, Kapha, water and earth. Now, at this point in our conversation, we were not yet examining the validity of any of these claims, any of these disciplines, in other words, whether we could still use them in this day and age. Quotes that we'll read for you here. The first one is by philosopher, author, recipient of several honorary doctorates. It's really hard to define him. Mario Bunge. The ancient Greeks made much of the difference between episteme or science and doxa or opinion. The postmoderns deny this difference, but the rest of us have kept it because we care for truth and well-grounded action. And another one by Rousseau, that doesn't really need any introduction: the worst man of science is he who is never an artist. And the worst artist is he who is never a man of science. In early times, medicine was an art, which took its place at the site of poetry and painting. Today they try to make a science of it, placing beside mathematics, astronomy, and physics. Now, two opposite and yet very similar perspectives. Let's start from Bung. Postmodernism. Without spending too much time analyzing what postmodernist philosophy actually is, I'm pretty sure that postmodern philosophy will still disagree with any type of description of that. But generally speaking, one of the issues here is the validity of certain absolute claim. Now, we're talking about science here, so we're not talking about absolute claim as in there are absolute truth. But there are certainly absolutely valid ways to investigate such truth. One of these ways is, by definition, the scientific method. Now, Bung mentions here episteme, or science. Now, this might be a voluntary mistake. Okay, episteme is one of the three types of knowledge. Whether we can equate knowledge with science, of course, is part of the theoretical debate here as well. But if both science and knowledge indicate something that we can know about things, that they involve a cognitive process, a research, an understanding, an empirical understanding even, then we should consider them synonymous. Now, according to Aristotle, as we will see in a future slide, there are three types of knowledge. Episteme is one of them. We will see that. The point that Bung is making here, however, is that doxa is just an opinion. Right? And so in other words, science is not up for debate. Science is by definition not a democratic process. In other words, to give you an example, if a person states that, I don't know, that norepinephrine is a gland, okay? It's not a hormone, it's not a neurotransmitter, it's the gland. And the other person states that it is not a gland, we cannot try to find a between line and kind of validate both opinions as if they were both valid. Science is in this sense not a democratic process because it has to disagree with the claim that norepinephrine is a gland. Right? Now, when Rousseau talks about medicine as art. And it's very interesting because, as I mentioned before, science in the context of medicine is just one part. In fact, the term doctor, to reconnect the previous conversation, did not, nor does, indicate physician in the vast majority of the history of medicine and also in the vast majority of country. In fact, it's not in the United States. In some other areas of the English-speaking world, where doctor is very often confused with physician. And to give you a straightforward example, the title of doctor in the United States does not require a doctorate, for instance, and therefore is equivalent to the degree of physician everywhere else in the world, so a bachelor or master level degree. Okay? And to this day, England, the UK, the Commonwealth still awards the MBBS as a degree. We'll see that more in depth. So that medicine bachelor or bachelor of surgery, so it's a bachelor degree, not because the training is different, because the degree is lower. And only if you get a full doctorate, you can be addressed as a real doctor. So in the United States, a real doctor is someone with a PhD, for instance, not with an MD. Historically speaking, also, there was a big difference between physician, surgeon, and doctor, where doctor was the highest possible academic achievement, comprising both theory and practice, and surgeon, so to speak, was the lowest one. It was almost the hands-on part of medicine, not different from a butcher, really. Someone who was very, very skilled at practicing medicine on the body of a person, but did not have any of the higher knowledge required from a physician, lower degree, and from a doctor, higher degree. I just mentioned this because medicine by definition is also an art, not because art is lower than science, because art in the history of human knowledge, it's neither above or below science, it's a different type of knowledge. In the next slide, we will briefly talk about health as a psychology and psychology as health. So we will combine medicine and this fascinating field within social science. Clinical medicine remains an interpretive practice based on practical reasoning or phronesis, and that's where Aristotle comes very handy. Now, phronesis is a term that can be very often translated with prudence, in a sense of both ethical understanding but also practical application of certain knowledge, understanding why, where, and how to apply certain knowledge. I will skip the definition here of phronesis from the perspective of rhetoric in Aristotle, but I would like to focus on the central concept here. So prudence as interpretation, prudence as motivation. So a good physician, a doctor, if you want to use the modern American English term, is someone who knows how to apply their knowledge by seeing the person, not the person against the standardized understanding of biostatistics, okay? Average data, but within that, understanding how specific, peculiar, and significant their individuality is. Other philosophers that I would like people to browse in this context, and the text examines that too, are Habermas, Hegel, and Foucault. Now, I would like to stop here for this first lecture to give you a general overview of some philosophical and theoretical consideration about our field, but we will talk more about the use of the term. Does it make sense to say that we have a complementary, alternative, and integrative medicine, or does it not? Well, thank you, and I will see you